The screens are on.
Good evening, everyone. Welcome to our program. Thanks for being here in person, and for those of you online, thanks for joining online. Tonight, we're going to talk about bladder cancer, and let me advance my slides here. Bladder cancer breakthroughs unpacked. We have a lot to talk about, so I'm going to get started. I'm Matt Galsky. I'm a medical oncologist at the Icahn School of Medicine at Mount Sinai, where I focus on bladder cancer. And I'm pleased to be joined by Dr. Shilpa Gupta from the Cleveland Clinic and Dr. Sia Daneshmand from USC, both experts in bladder cancer. Thank you to Peerview and World Bladder Cancer Patient Coalition for providing this session, and Astellas Pfizer, Johnson & Johnson, Merck for providing the educational grants for the symposium. If you haven't already, please complete the pre-event survey. For in-room learners, use the personal device to scan the QR code on the slides to respond to the polls and ask us questions. And please ask questions. I'll receive those in an iPad up here, and we'll be able to respond intermittently throughout the session. And for virtual learners, please respond to polls on your screen and enter questions in the chat window. Please scan this QR code if you're in the room here. Participate and win a $50 gift card. I'll give you a second to scan that. Okay. And here is the website for access to the slides, and all of the slides will be available from tonight. So let's start with this question. Which of the following represents a challenge to your treatment decision-making for patients with bladder cancer at your practice or institution? Select all that apply. Understanding available and emerging options for non-muscle invasive bladder cancer, determining the best approach for muscle-invasive bladder cancer therapy, selecting treatments for patients with metastatic urothelial cancer, providing patient education for available therapies, AE management considerations, awareness of clinical trial opportunities. Please provide your answers. Okay, so we have number one, understanding available and emerging options for non-muscle invasive bladder cancer, and then number two, determining the best approaches for muscle invasive bladder cancer, but really interest in learning about all of these different topics, which is great because we're going to cover all of these topics. So today we're going to learn about clinical trial and real-world evidence supporting FDA-approved therapies in urothelial cancer throughout the clinical disease states, individualized treatment plans, and effectively managing adverse events with emerging therapies. So let's get started with non-muscle invasive bladder cancer. Dr. Daneshmand.
Great, thank you, Matt, and thank you for coming to this symposium. So there's a lot going on in non-muscle invasive bladder cancer. I'll get right into it. I'm Sia Daneshmand. I'm a professor of urology and medical oncology at USC, Norris Comprehensive Cancer Center. Okay, so we always want to talk stage first, and I think many of you will be familiar with the stages of bladder cancer, but just to reiterate, non-muscle invasive bladder cancer does include T1, which is invasive, but not muscle invasive. So we like to categorize patients into non-muscle invasive and muscle invasive. And this is how I talk to patients. And within the non-muscle invasive categories, we have high risk, intermediate risk, and low risk. And the high risk is easy. Any patient with high-grade TA, larger tumors, any T1 variant histology, carcinoma in situ is considered high risk. And intermediate risk would be the recurrent low-grade tumors, and for at least the AUA definition, a small high-grade TA lesion. And then the low risk are the small, usually low-grade papillary urothelial carcinomas. So most of the talk will be focused on the high-risk patients. And progression is really the main concern. We want to keep these patients from progressing to muscle-invasive disease. Whereas in intermediate risk disease, we talk a little bit more about recurrence and trying to reduce the recurrence rates. The low-risk patients, the very small papillary low-risk patients, you're not going to see much as medical oncologists because we usually just resect those patients and don't give them further treatment other than the perioperative chemotherapy. Okay, these are the NCCN treatment guidelines. A lot has been added since 5 years ago. We now have several approved therapies. I'm not going to go through all of them, but just to show you that this does appear in the NCCN treatment guidelines that have been recently updated for both papillary and papillary disease with or without CIS. And that'll be a theme tonight where I keep talking about CIS with or without papillary disease because that's how many of these trials were done. So these are the treatment approaches for high-risk non-muscle invasive disease that's unresponsive to BCG. We have now combination therapies, BCG with checkpoint inhibitors. You see that up top. We have several intravesical options, and we'll go through those a little bit, and then briefly touch upon some of the clinical trials that are underway for novel therapeutics in this space. So gemcitabine and docetaxel, this is intravesical therapy. We've been using it for a number of years for BCG unresponsive disease. But given the BCG shortage, one of the important trials that was relatively recently completed was this phase 3 bridge trial. These are patients who have never had BCG. They were randomized upfront to gemdosi versus BCG. Very simple, straightforward trial. We participated, put a number of patients on this trial, and patients also get maintenance therapy on both arms. So gemdosi is given sequentially. We give the gemcitabine first. It's evacuated, then we put the docetaxel in intravesically, and the patient goes home. So comparing these regimens, we don't have any results, but this is a very important trial that may show us non-inferiority of using a combination chemotherapy up front in BCG-naive patients. So we've had pembrolizumab available to us for a number of years. This was one of the first trials that was run for BCG unresponsive high-risk non-muscle invasive bladder cancer. This was the Keynote 057 study, and this included patients CIS with or without papillary disease, so high-grade TA and T1, and had to have CIS. So in January 2020, pembrolizumab was FDA approved based on this trial. And the trial was very simple, basically BCG plus pembro versus BCG alone, and patients were followed. 1,400 patient trial. I'm sorry, the pembro alone arm was a Keynote 057 that was showing the median duration of response to be 16 months, and you can see the response there and the 50%, the duration of response there. The Keynote 676 is BCG plus pembro versus BCG, 1,400 patient trial. These are for BCG naive patients. So the Potomac study, now we're going to get into the BCG with immunotherapies. The Potomac study was looking at high-risk non-muscle invasive bladder cancer, again, any high-grade disease, any T1, and it looked at, and this is a common theme here, BCG induction only with durvalumab, BCG induction and maintenance with durvalumab versus BCG induction and maintenance. So essentially 3 arms. And you can see the difference there. The primary endpoint was met. The hazard ratio was 0.68. The combination of BCG with durvalumab afforded a greater response rate than BCG alone with maintenance. So this is a very, very recent FDA approval. So now we have durvalumab as an adjunct. This is where I think medical oncologists need to become familiar with non-muscle invasive bladder cancer, because this is something that we're starting to talk to patients about in terms of what is the most effective therapy you have right now for BCG naive patients. And so again, just a very, very recent approval. What about potential for improving daily management? We now, as many of you know, we have the subcutaneous IO formulations. It allows for more flexibility, I think reduces preparation time and administration times. And also, some urologists have these available to them in their office, not so much in academic centers, but in some community centers where giving a subcutaneous formulation of checkpoint inhibitors might be easier for the patient. So the CREST trial was looking at the benefit of the subcutaneous sasanlimab with BCG plus maintenance versus BCG with maintenance alone. And again, this showed that the addition of a checkpoint inhibitor added to the benefit, and you can see that there's about a 5 or 6% benefit. But if you look at the event-free survival, it was 32% lower with the subcutaneous sasanlimab with BCG with maintenance when you compared it to BCG with maintenance alone. So this is not yet FDA approved, but certainly met its primary endpoint, and you can see the tail end of those go out to over 5 years. There's higher CR and duration of response in CIS with subcutaneous sasanlimab with BCG and maintenance versus BCG induction and maintenance alone. You can see the separation of the curves there. So clearly an effective regimen, and the safety profile of sasanlimab was consistent with the known profile of each of the drugs individually. Quality of life was, for the most part, maintained with the combination therapy there. So these are the FDA-approved intravesical treatments for high-risk non-muscle invasive bladder cancer that's unresponsive to BCG. So the first one was, well, we talked about pembrolizumab as being the first one. In December 2022, we had the viral gene transfer nadofaragene firadenovec, and these are all approvals for essentially the same thing. And in April of 24, we had the IL-15 superagonist, nogapendecan alpha invecept, otherwise known as Anktiva. And then very recently, in September of 2025, we had the intravesical drug delivery system. This is the very first of its kind, the sustained release of gemcitabine through this device that's placed inside the bladder. Indications are, again, all same thing. So now we are beginning to have a number of agents to use in the BCG unresponsive space. So this is the GEM-IDRS, the intravesical drug delivery system or drug releasing system for non-muscle invasive bladder cancer. It's placed in the bladder via a special catheter, very easy to do. The catheter is very similar to what we use for intravesical treatment. And you can see that this device is deployed in the bladder, and it has little pellets of gemcitabine in there that will elute over time in the bladder. And the idea is that sustained release is better than just the 1 hour usual formulation we did. There are some really nice, elegant studies showing the penetration of the drug metabolites in the deeper layers of the bladder within 3 to 5 days of the releasing system. So this was the trial that led to its approval. It's a phase 2b Sunrise 1 trial. It's a GEM-IDRS and BCG unresponsive high-risk non-muscle invasive bladder cancer. There were multiple cohorts, but just look at the middle there. And by the way, these slides are all going to be available. I'm not going to go through details on any of these slides. I just want to show sort of the highlights of some of these trials. But just look at the middle one there was the GEM-IDRS monotherapy, the cohort 2. That was the cohort of interest. And the GEM-IDRS dosing was every 3 weeks for the first 24 weeks, then quarterly through week 96. And the primary endpoint, of course, was CR rates. There was another cohort added, and you can see that was the cohort 4, and that was for papillary disease. Here's a swimmer plot, but again, what I want you to concentrate on is the overall CR rate here that was centrally assessed on these patients. And the CR rates at any time were 82%. So this is one of the highest CR rates we've seen for any intravesical drug system or intravesical chemotherapy. And this is pretty well sustained throughout the year. You can see the 1-year results there. The recurrence and progression rates were fairly low. The estimated 12 and 24-month recurrence rates you can see there is 86 and 75% for 24 months. These are estimated curves. So as you saw in the previous slide, in the swimmer's plot, there are several patients, and some of those patients are actually my patients who are out several years after therapy without recurrence. Again, they do get maintenance therapy. So this is for that cohort 4 that I just showed you. This is for papillary disease only. And this was a smaller cohort of patients, but you can see that at the 12-month mark, 74% of the patients were disease-free. and had not had recurrence. So also very effective in the adjuvant setting for papillary disease. The distinction here for papillary versus CIS is that CIS, from our urologic standpoint, when we do our transurethral resection, we're not completely eliminating the disease. This is surface disease, whereas papillary tumors we're actually removing, so this becomes adjuvant therapy really. Whereas for the CIS, which is what FDA wants to see, is actual clearance of the disease. So that's what the distinction is. Very few progression events. Obviously, most of these patients are surviving their disease. Only one progression event was reported among the 52 patients in that cohort. And only 7% of the patients subsequently underwent radical cystectomy over about a 1.5-year period. So most of the patients are retaining their bladder, which is a good thing. All right, we mentioned nadofaragene firadenavac. This is a non-replicating adenoviral vector-based gene therapy. It delivers the interferon alpha-2b cDNA into the urothelial cells and enhances this viral transduction. And this is transcribed within the cells, and it basically makes a factory of this interferon alpha-2b from the cells that sheds into the bladder and lyses the cells and brings in sort of the immune mechanism to inhibit tumor growth. So again, this has been FDA approved since 2022, and we recently had a 5-year follow-up on these patients. This is a one-time installation every 3 months, so very, very convenient for the patients to have a single installation of bladder as opposed to once a week for 6 weeks. And the 1 year freedom for the complete response rates were about 50%. At 1 year, it was approximately 25%. But there were, out of the original cohort of patients, there were about 5 left who had more than 5-year follow-up and were still disease-free. Now we're looking at combination therapy and some ongoing trials right now. So we mentioned Anktiva, or the IL-15 superagonist. This is nogopendecan and Becept. I don't know how they come up with these names, but this is a mouthful. This is, again, IL-15 superagonist, and it works to lyse the cells. I'm not going to go into the details of the mechanism. Very well tolerated and excellent results in their pivotal trial here, the QUILT trial against CIS with or without papillary disease. CR rates were 71%, and it was maintained in about half the patients with follow-up of more than 45 months. So patients we're now seeing duration of responses more than 3 years for some of these drugs. And cystectomy-free, again, which is the goal for these patients, is to keep them from undergoing a cystectomy, is about 84%, which is great. They do have a papillary-only cohort, and you can see the results there are excellent as well, 82%, and disease-specific survival of 96%. Okay, what are the ongoing studies? I briefly mentioned ABLE-22. ABLE-22 is a phase 2 study looking at nadofaragene with or without chemotherapy, doublet chemotherapy, gemcitabine and docetaxel. That's the top here. So this is basically nadofaragene. This is nadofaragene with gemdosi. There was a third arm, nadofaragene with pembrolizumab, but this arm is now closed. So basically, we're comparing nado with nado plus gemdosi, and this is for CIS with or without papillary disease in BCG unresponsive disease. ABLE-22, this is ongoing as a global trial. There's an ABLE-32 study that is very, very similar, looking at non-muscle invasive bladder cancer in the intermediate risk cohort, which I mentioned in the beginning. And this is randomizing patients between nadofaragene versus observation. And you would ask, why observation? Because we really don't have a standard of care for treatment for intermediate risk disease. You can use BCG, you can use gemcitabine alone, but there's really no standard of care. So if you look at the guidelines, observation is still in there in both NCCN and AUA guidelines. That's why it's being tested against observation. There's other ongoing studies with GEM-IDRS. There's a phase 3, the Sunrise 3 study in the BCG naive population. Again, you saw the combination with checkpoint inhibitors. This is that GEM-IDRS intravesical system, comparing it with BCG, and then the GEM-IDRS cohort C given with citralumab, which is this first one is with citrilimab, this is without. Citrilimab is a PD-1 inhibitor. So it's a combination therapy of the Gem-IDRS with citrilimab versus BCG versus just the Gem-IDRS. We don't have results for this yet. It's ongoing follow-up for these patients. And then there's a Sunrise 5 study, which is very similar to Sunrise 1, except it's in papillary-only disease. Again, all these drugs are also trying to get an indication for papillary-only disease as well. So it's comparing the Gem-IDRS versus intravesical chemotherapy, gemcitabine or mitomycin. How about FGFR3 inhibition in non-muscle invasive bladder cancer? Obviously, we're familiar with the metastatic disease and the FDA-approved erdafitinib in that trial, but it's actually FGFR3 alterations are more common in patients with non-muscle invasive bladder cancer, and when you get to low-risk disease, it's actually even higher FGFR3 alterations. So you can be seen in approximately 70% of patients with intermediate risk disease. So this provides a target for the drug, and this was a study looking at use of erdafitinib intravesically for patients, and this followed another trial called Thor-2 where oral erdafitinib was used. But this is basically the study schema here. I showed you the Gem-IDRS. Now this is erda-IDRS, so erdafitinib in the pretzel-shaped device that's placed inside the bladder. And these patients get it once every 3 months. It's a very, very convenient schedule of dosing for the patients. And this is being compared to intravesical chemotherapy with either gemcitabine or mitomycin. So that's investigator choice for intermediate risk disease. 1-to-1 randomization, and we're awaiting results. But the first in human study, the results are really quite excellent. So there are other studies as well with the erda-IDRS. There's a phase 2 called Moonrise 2. So we have the Sunrise studies and we have the Moonrise studies. This is intermediate risk patients, and this is in the ablative setting. Can we actually not have patients undergo the TURBT to begin with? And this would be a huge advance for patients, so we don't have to take them to the OR, we don't have to stop the anticoagulation and so on and so forth, get pre-op. So this is in the ablative setting, so we leave a visible tumor behind without surgery and then put the erda-IDRS in there. And then the phase 3 Moonrise 3 study is a high-risk papillary non-muscle invasive bladder cancer who've received prior BCG therapy. So BCG unresponsive disease as well. Oncolytic adenovirus advances, so the CG, or otherwise known as cretostimogene grenadenorepvec, CG0070, is an oncolytic vaccine essentially engineered to express GM-CSF and replicate selectively in tumor cells with mutated or deficient RB pathway. So this is, the Core 001 was a single-arm study of Creto plus Pembro in patients with BCG unresponsive disease. The CR rate at 2-year mark was 54%. The Bond 003 study was looking at basically the same thing. This is pathologically confirmed high-risk BCG unresponsive disease, and this was without any checkpoint. And you see the CR, it was felt that, maybe the response rates are high enough, we don't really need the checkpoint inhibition. And you can see the very high response rates here in the 75% range. This is really, the bar has been raised for this, and this has FDA fast track review. And lastly, the Legend study, this is yet another mechanism. This is detalimogene voraplasmid, again, looking at multiple different cohorts of BCG unresponsive, BCG exposed, BCG naive, and patients are treated with several cycles. And we have some preliminary results that are looking quite good. And for interest of time, I think I'll move on. So safety consideration, generally all of these treatments that I just mentioned are well tolerated. The systemic therapy, there's no additional signals with the use of either BCG or any other intravesical treatments. And these are side effects that we're all very, very accustomed to, or the patients are accustomed to, the dysuria, the urgency, frequency, and things like that. So most of them are grade 1 and 2. So, all right, I'll stop there.
Thank you. Thanks for that whirlwind tour through
Hi.
acronyms and letters and numbers. You got all that straight, right? But the slides are available, so please download the slides for review. So let's reinforce some of that through a case. So this is Mary. She's 73 years old. She has carcinoma in situ and high-grade TA disease. She is considered to have BCG unresponsive disease based on her prior treatment. She undergoes a repeat TURBT and there's no residual tumor. On her prior treatment with BCG, she had some side effects, some fatigue, low-grade fever, and she does have a small bladder capacity. She lives a while from the clinic, 20 miles away, and she needs short clinic visits and relies on her neighbor for transportation. So I think as we get more and more treatments, of course, some of these considerations in terms of logistics and what's most convenient for patients actually does come into play. So, Sia, I'd like if you could take us through how you think about Mary's situation, but maybe in part when doing that, an audience question came in. Do you think determining BCG unresponsiveness is a challenge for care teams? So in clinical practice, do you actually look at the definition and sort of see if they meet the definition or not, or is it more sort of gestalt in the clinic?
Yeah, it's a great question. For the trials especially, we had to. It has to be exactly within 1 year, 365 days. But in practice, now that we have some of these drugs available to us, obviously it's more of a gestalt. Patients had BCG, that was interrupted, took 1 year and 3 months to complete all therapies. But she meets the definition of BCG unresponsive disease. So like we mentioned, there's gemcitabine docetaxel, there's pembrolizumab, checkpoint inhibition. We have clinical trials if she's eligible, and then we have nadofaragene firadenovec and Inlexzo and Anktiva. So we actually have a number of options, right? So this, her living 20 miles away, having some transportation issues actually comes into the conversation. Some of these are somewhat labor intensive. The number of visits they need to come in for. In Inlexzo, for instance, you do need to come in every 3 weeks for the insertion and removal and reinsertion of the next one. So like I mentioned, for the first 24 weeks, it's every 3 weeks back and forth. That might be okay for some patients, and it's really only a few minutes to do these things. But this is where perhaps Adstiladrin, even though the efficacy of nadofaragene firadenovec may not be as high as the other ones, may be suitable for her. And you don't burn any bridges. That's what I like about these therapies, is they all work in different ways. The mechanism of action is completely different. So by using one, you don't burn a bridge to the other. And I think it's fairly safe to try one. So I would be leaning toward nadofaragene for her, but certainly Inlexzo, if she can come in every 3 weeks, that would be another. Inlexzo would be the GEM IDRS system when it's just once every 3 weeks, only for the first 6 months. Once we pass the 6 months, it's once a quarter. If she's continues to respond, I think that's another option for her.
And how do you know if the treatments are working for any of these treatments?
Yeah, so we do our routine surveillance cystoscopies every 3 months, and judicious use of CT scans, but mostly we're looking inside the bladder every 3 months.
Dr. Gupta, any role for genomic testing in a patient like this?
Yeah, I mean, we are usually doing genomic testing when they are, advanced disease, but I think nowadays it's best to do it anytime patients are diagnosed, so it's good to have that information.
And Dr. Daneshmand, how's the impact of the BCG shortage impacted your treatment decisions, both in a patient who's BCG naive and then particularly in this situation?
Yeah, it's a good question. So she's BCG unresponsive, so we wouldn't be using BCG. However, Anktiva, the IL-15 superagonist that I mentioned, actually uses BCG as well. So we have not been able, until very recently, be able to use Anktiva for this purpose. However, recently they did get a recombinant BCG available to us, and we just got that through our IRB, and it's available to us. So we're now using recombinant BCG with the IL-15 superagonist, the Anktiva. So that is an option for her as well.
Great, thank you. So we're going to move on. What treatment would you offer, Mary? Please go ahead and log in your answers. Nadofaragene firadenovec, NAI plus BCG, GEM-IDRS, pembrolizumab, either intravenous or subcutaneous, sasanlimab subcutaneously, or you're not sure. Okay, it looks like we have GEM-IDRS as the winner tonight. Okay, let's move on, and let's talk about muscle-invasive bladder cancer. Lots of changes in the muscle-invasive bladder cancer landscape in just the past few years. For patients who are considered cisplatin ineligible, and that's generally been an arbitrary line in the sand in terms of which patients have a higher risk for treatment-related toxicities with cisplatin, for whom we're hesitant based on the balance of risk versus benefit. For patients who meet that definition historically, in the muscle-invasive bladder cancer setting, cystectomy alone has been the standard treatment. Really, there's been an inability to demonstrate that systemic therapies provide benefit aside from cisplatin-based chemotherapy historically, and that's been a major unmet need in the field. Historically, with cystectomy alone, if you look at an all-comer population with muscle-invasive bladder cancer treated with local therapy alone, the risk for recurrence is as high as 50% in some series. And so there's really been a need to try and address this risk of micrometastatic disease, not only for our patients who can receive cisplatin, but for all of our patients. And there's been a paucity of trials studying therapies in that setting, in particular because we've had a lack of effective therapies in this disease beyond cisplatin-based chemotherapy until just the past 10 to 15 years. And now there are several new therapies, non-cross-resistant novel mechanisms of action. The trials that have been conducted in the population of patients with muscle-invasive bladder cancer who are ineligible to receive cisplatin-based chemotherapy have generally fallen into two buckets recently. Those trials exploring the combination of the antibody-drug conjugate enfortumab vedotin plus immune checkpoint blockade. So the KEYNOTE-905 study, pembro plus enfortumab vedotin, and then the VOLGA study, durvalumab plus enfortumab vedotin, and there's an arm with tremelimumab, the CTLA-4 inhibitor as well. The other study, the SUNRISE-4 study in this context, used the regimen that we heard about from Dr. Daneshmand, the GEM-IDRS system plus citralumab. So we'll talk about each of these in a little bit more detail. You can see for KEYNOTE-905 and VOLGA, the schema has been the schema that's shown on the slide, which is this what's referred to as a sandwich approach of giving systemic therapy, then patients undergo cystectomy, and then additional systemic therapy after that surgery. And there's a lot of discussion about contribution of phase of therapy in this situation, but these are the ways that the studies were designed. So here's the KEYNOTE-905 study, also referred to as EV-303. And this study enrolled patients with muscle-invasive bladder cancer with no evidence of metastatic disease, so clinically localized disease. And patients were, again, ineligible to receive cisplatin-based chemotherapy based on criteria that mostly are related to renal function. And individuals were randomized to receive either enfortumab vedotin plus pembrolizumab for 3 cycles, followed by cystectomy, followed by an additional 6 cycles of EV plus pembro, and then single-agent pembro to complete 14 cycles. That's the experimental arm, or cystectomy alone. There was an additional arm on this study, which was the way that the study was initially designed, with pembro only, and then that arm closed early in favor of enrolling patients onto the EV pembro arm after the activity of EV pembro was demonstrated in the metastatic setting. The primary endpoint of the study was event-free survival, and you can see here a major benefit in terms of event-free survival. Not often that we see hazard ratios of 0.4 and You can see with cystectomy alone what I was referring to before, which is the unfortunately high risk for recurrence without systemic therapy. Here's the overall survival data and also an overall survival benefit with a hazard ratio of 0.5. These results were initially presented at ESMO and subsequently published in the New England Journal of Medicine and subsequently led to an FDA approval for perioperative EV Pembro for patients with muscle-invasive bladder cancer who are ineligible for cisplatin-based chemotherapy. Here you see the PathCR data with GemCis versus EV Pembro. I'm sorry, this should not be with GemCis. That's with cystectomy alone. So we know that some patients who undergo a TURBT, when urologic oncologists like Dr. Daneshmand take those patients to the operating room and remove the bladder, in a small subset of patients, that transurethral resection has actually resected all tumor, and those patients can have a PathCR. But you can see here that rate in this study was 8.6%. So a pretty low likelihood of that occurring without systemic therapy. With systemic therapy on this study, a PathCR rate of 57.1%. So more than half of patients are achieving PathCRs with this regimen. And you can see here an observation in the Kaplan-Meier curves that's been made multiple times with different treatment regimens, which is that patients who achieve a PathCR have a higher likelihood of deriving long-term benefit. Of course, not because of what happened in the primary tumor in this situation, because the primary tumor is removed, but probably because this is a surrogate for eradication of micrometastatic disease. Some updates from Keynote 905 at this meeting. Quality of life data was presented. This is an important quality of life analysis for two reasons. One, because these patients were ineligible to receive cisplatin-based chemotherapy, and that often goes along with other comorbidities, and so we need to be quite careful about balancing risk versus benefit, particularly in this population, and particularly with a surgery like cystectomy. And so in this analysis, and the other reason, of course, this was important is because it's systemic therapy versus no systemic therapy, rather than some other studies which randomized between different systemic therapy options. So you can see here with the addition of EV Pembro, no significant detriment in terms of quality of life. Very important in the context of the benefit that's achieved with the regimen. An additional piece of data from the meeting is subgroup analysis. We're often struggling with ways to identify which patients can be cured with cystectomy alone so that we don't subject patients to the potential risks of systemic therapy who don't need it. And you can see here that based on clinical staging of tumors, this alone cannot determine which patients benefit from perioperative EV Pembro versus not. Even in patients with clinical T2 disease, recognizing the limitations of clinical staging of bladder cancer, even patients with clinical T2 disease derived benefit in this subgroup analysis. The VOLGA study is similarly designed with a few nuances. So VOLGA, as mentioned, is durvalumab plus enfortumab vedotin in the neoadjuvant setting, followed by cystectomy. But after cystectomy, the adjuvant therapy is immune checkpoint blockade alone, so the enfortumab vedotin is dropped. So that's a difference with Keynote 905. The other difference is the third arm, which includes the combination of durvalumab plus tremelimumab plus enfortumab vedotin in the neoadjuvant setting. And then the control arm is the same as Keynote 905, cystectomy alone. We heard a press release about VOLGA just recently, which reported a statistically significant improvement in EFS and OS in this study as well. So certainly reinforcing what was seen with Keynote 905 will be really important to see these data. There was also an improvement in EFS with the durva-tremi plus EV arm, but OS did not reach significance at the time of this initial analysis, so also will be interesting to see what the potential is for that triplet regimen. Sunrise, is noted before, is taking a different strategy. So this Sunrise 4 study involved administering the GEM IDRS system, this pretzel with gemcitabine inside it, which slowly releases into the bladder, plus systemic immune checkpoint blockade in the neoadjuvant setting in patients with muscle-invasive bladder cancer. And then there's a cohort with immune checkpoint blockade alone. We know from a series of mostly single-arm phase 2 studies that single-agent PD-1 or PD-L1 blockade has activity in the neoadjuvant setting in muscle-invasive bladder cancer with path CR rates in the range of about 30 to 40%. So this was important to have as a control arm. And then, of course, a very interesting approach trying to use an intravesical therapy in the in the muscle-invasive bladder cancer setting, something that we've talked about as a field for a while, but really had not been studied in a rigorous manner. Now we have data from this meeting with intravesical BCG in muscle-invasive bladder cancer. So this is a concept that is gaining steam after having been discussed for really quite some time. So this is the Sunrise 4. And here you can see the path CR rates. And if you give this GEM IDRS system plus citrilimab, you can see a bump in the path CR rates versus citrilimab alone, path CR rate of 42% with the combination. So interesting data. Please log in your answers to this question. How does the FDA approval of perioperative EV Pembro for patients with muscle-invasive bladder cancer who are cisplatin ineligible change your treatment approach? One, I still plan to use neoadjuvant chemotherapy for patients who are cisplatin ineligible. Two, EV Pembro provides a new option with significant efficacy and manageable safety for patients with muscle-invasive bladder cancer who are ineligible for cisplatin-based therapy. Three, I'd like to wait for further data readouts, or four, I'm not sure. Go ahead and log in your answers. And please send any questions that you have. So EV plus P provides a new option with significant efficacy and manageable safety for patients with muscle-invasive bladder cancer who are ineligible for cisplatin-based therapy. The majority of you answered that. And then for the first one, I still plan to use neoadjuvant chemotherapy. So neoadjuvant chemotherapy, as mentioned, historically we haven't had cytotoxic chemotherapy regimens that have been shown to be effective in randomized studies in the neoadjuvant setting for patients who are cisplatin ineligible. That said, in the Niagara study, which I'm going to mention, giving cisplatin-based chemotherapy in a manner that splits the dose of cisplatin, one can administer that regimen to patients with a lower GFR safely. So we'll talk about that a little bit more. So here are the studies of perioperative therapy for patients who are cisplatin eligible. And we have Niagara, GemCis plus or minus durvalumab. We have Energize, GemCis plus or minus Nivo. We have Keynote 866, GemCis plus or minus Pembro. So three studies designed in a very similar manner, asking a very similar question. And then we have Keynote B15, which is perioperative EV Pembro, just like I just showed you in the Keynote 905 study. Again, the study designs were quite similar to what we saw in the prior slide, which is this sandwich approach of systemic therapy before and after cystectomy. Of course, the difference in design here is that the comparator is not cystectomy alone, but it is neoadjuvant GemCis followed by cystectomy. Here's the Niagara data. Patients who are cisplatin eligible, who have muscle-invasive bladder cancer, randomized to receive GemCis Durva for 4 cycles, followed by cystectomy, followed by adjuvant Durva for 8 cycles, versus neoadjuvant GemCis followed by radical cystectomy. Event-free survival was the primary endpoint of the study. The study met its primary endpoint, was approved by the FDA in March of 2025. Here you see the EFS benefit with GemCis durvalumab with a hazard ratio of 0.68. And this regimen was rapidly adopted in clinical practice. And here's EFS by pathological stage. So you see, as mentioned before with Keynote 905, that patients who achieve a path CR have better outcomes, but you don't have to have a path CR to derive benefit from the addition of immune checkpoint blockade in the studies you see in the bottom curves. And that sort of makes sense to us clinically. There are certainly patients that we treat in the clinic who have large, bulky tumors initially, who we see downstaging of their tumor radiographically. We see improvement in symptoms, improvement in renal function sometimes, but the response in the bladder just is not sufficient for a path CR. So it's a relatively crude measure, identifies, of course, patients who derive the most benefit, but not all patients who derive benefit. Here's the adverse events on Niagara, and you see that with the addition of immune checkpoint blockade, you see an adverse event profile very consistent with what we see in other settings where we add cytotoxic chemotherapy and immune checkpoint inhibitors. You don't see synergistic toxicity. You see the independent toxicities of the different treatment portions. We're awaiting results from Keynote 866 and Energize. These are the other studies testing cisplatin-based chemotherapy with or without immune checkpoint blockade. Hopefully we'll see the results of these studies in the next year. Here's Keynote B15. Keynote B15 enrolled patients who are cisplatin ineligible, designed similarly to Keynote 905, as mentioned. Patients were randomized to EV Pembro perioperatively versus Gem-Cis with cystectomy. Some nuances with Keynote B15 compared to 905. 4 cycles of neoadjuvant therapy were given instead of 3. That was really to make the neoadjuvant cycles equal compared to neoadjuvant Gem-Cis. And then there's a shorter adjuvant portion as a result of that. Primary endpoint was event-free survival. And here you see the EFS data, hazard ratio of 0.53, substantial benefit compared to cisplatin-based chemotherapy, and really the first non-cisplatin-based regimen to show a benefit in the perioperative setting in muscle-invasive bladder cancer, and really the first non-cisplatin-based regimen to beat a cisplatin-based regimen in this setting. Here's the overall survival data, also showing a significant improvement with a hazard ratio of 0.65. And here's the path CR data. So the path CR data line up really quite well with what we saw with Keynote 905, with a path CR rate of 55.8%. There are some updates from Keynote B15 being presented tomorrow, some subgroup analyses, so be sure to check those out. Here's the adverse event profile from Keynote B15, and what you can see is that the adverse events are just different with EV Pembro versus Gem-Cis. We know this from the metastatic setting. No surprises in terms of adverse events in the perioperative setting. With EV Pembro, we see more pruritus, we see more rash, we see more neuropathy. With Gem-Cis, we see more cytopenias, we see more nausea and vomiting. So the muscle-invasive bladder cancer treatment paradigm has markedly shifted with the introduction of immune checkpoint blockade, and then more recently with the addition of perioperative EV Pembro. There are ongoing trials that we haven't seen the results for, which can shift practice patterns further. So let's talk about Alan. Alan's 79 years old. He presents with hematuria. He has a cystoscopy, which shows a mass in the anterior bladder wall, has a TURBT, which shows muscle-invasive urothelial cancer. His creatinine clearance is 40, and he has a history of hypertension, but he's otherwise well. So Dr. Gupta, how do you think about Alan? What would you counsel him?
So this is, a lot of patients we see like this, and borderline creatinine clearance, otherwise pretty healthy. So if the patient is fit for cystectomy, in the past we would just send for upfront cystectomy, but now we have this regimen that you just showed the amazing data from EV and Pembro. So we will provide information on that to the patient. Now, with this creatinine clearance, I would like to say that split dose of gemcitabine, cisplatin, and durvalumab is also an option. But I would say that, seeing the EV Pembro data, that would be more appropriate to offer this patient, given the incremental benefit we've seen in survival. But we do have to counsel the patient about the unique toxicities that one can see with EV Pembro.
And before EV Pembro was available in the setting, Gem/Cis Durva, creatinine clearance of 40, you're pretty comfortable with split dose cisplatin in that setting?
Yeah, definitely. I think Niagara trial was a very forward-looking trial. Before Niagara came out, I was comfortable if creatinine clearance was in the late 40s. We would use split dose all the time. If it was less than 60 but more than late 40s. But now seeing that in Niagara they specifically use split dose for creatinine clearance as low as 40, that was very, very reassuring, and I was comfortable doing that.
Dr. Daneshmand, ctDNA in this setting, are you doing it? When do you send it?
Yeah, definitely. So we're sending it, we have the kits in our clinic. We're sending it at diagnosis, and we coordinate with our medical oncologist if we're sending for neoadjuvant therapy. But certainly, we want to know what the ctDNA is prior so that we can follow it and have meaning afterwards. So one other thing to consider, I know you didn't ask me, but I'm just going to offer my 2 cents here. Creatinine clearance of 40 in a patient like this, obviously he has a history of hypertension, which may be the cause of his CKD. But one thing to consider is always obstruction, and that this could get better, right? So if you have some hydronephrosis, you can put in a percutaneous nephrostomy tube and improve that creatinine clearance. So it's not a one-time, thing. I always like to see multiple values of creatinine, get a sense of the patient's renal function. But I guess with EV Pembro, it doesn't really matter as much as it has in the past.
Does your threshold for recommending patients have a percutaneous nephrostomy tube change at the time of diagnosis with EV Pembro? Not so much that you're worried about treatment-related toxicity, but in terms of maybe the treatment working quickly and relieving that obstruction?
Yeah, that's a great point. I think in the past, if we had borderline function and we're sending for Gem/Cis, cytotoxic therapy, it tends to work a little bit quicker. And so if we were sort of on the fence and it was going to be a week before they got their percutaneous nephrostomy tubes, we would send them for Gem/Cis. But now with EV Pembro, I think it takes probably a little bit longer to take effect. So we want to protect as much kidney function as possible. So I think we're a little bit more inclined to send patients for percutaneous nephrostomy tubes in that setting.
And can you tell us a little bit about how you think about surgery differently or not differently in patients who have received these various regimens?
Not really. It's a whole discussion, actually. So obviously we've got decades of experience with cisplatin-based neoadjuvant chemotherapy and followed by surgery. Lots of papers and studies showing that the complication rates are no different. There is this whole conversation brewing among my colleagues about cystectomy being much more difficult after neoadjuvant EV Pembro. However, the disclaimer there is I think it hasn't been really widely used. It's always been used for locally advanced disease and metastatic disease, and the cystectomies we're doing in that setting are because of the tremendous response that they've had. So to me, it's more of just a response rather than the drug itself. It's a fibrosis and desmoplastic reaction, the same we see with seminomas, for instance, treated with cisplatin. We get this tremendous desmoplastic fibrotic reaction. So that's what we're seeing. I suspect, and we're just beginning to do cystectomies post-neoadjuvant EV Pembro, I suspect that cystectomy will not look very different because we won't have that exuberant response to it.
Dr. Gupta, I hear some people say that they'll send ctDNA, and if it's undetectable, then defer neoadjuvant therapy and recommend patients undergo surgery. How do you think about that?
Yeah, no, I don't think we are ready for prime time to make decisions based on ctDNA. Those are hypothetical situations, and I think if somebody's ctDNA is negative, there's nothing to prove that cystectomy in that patient is going to improve survival.
So we saw from Niagara, of course, and we don't have data from some of the other studies yet, but in Niagara, patients with undetectable baseline ctDNA certainly had a better prognosis than patients with detectable, but still benefited from the addition of immune checkpoint blockade, suggesting that systemic therapy in general still has the potential to improve outcomes.
Absolutely.
And anything else that you would counsel, Alan, in terms of the postoperative setting? So when do you start to talk about what happens after surgery when you're having all these discussions about neoadjuvant treatment and surgery?
So I think, because this was the sandwich approach, no matter what the response is and what the response is at cystectomy, patients got 6 more cycles of adjuvant treatment. But in our experience, the cystectomy, because it's such a big life-altering procedure, it really depends on how the patient is doing post-op and when you are seeing. I know on the study, we are seeing as soon as 4 weeks, and sometimes patients hadn't really fully recovered. And if they had some toxicities from the neoadjuvant portion, which are just blossoming up, then it becomes really hard to push for therapy at that time. So I think we have to see it in the context of the patient in front of us. If the patient has a complete pathologic response and patient is still struggling from some toxicities and trying to recover from cystectomy, ctDNA is negative, we could think of alternative things. But going by what the study showed, that we should talk about the adjuvant portion too, because we really don't know how much the neoadjuvant portion added to survival benefit versus the adjuvant. So I think we try to offer the adjuvant treatment whenever possible. And if they're not in a state to receive EV, at least offer pembrolizumab.
And you start talking about the adjuvant portion in the same initial discussion with patients?
So patients are not kind of taken by surprise, because then some patients say, well, I wasn't prepared for this, and why do I need more therapy?
Yeah. Dr. Daneshmand, related to surgery, do you have to think about diversions any differently with various regimens?
Yeah, certainly. Oh, with various regimens, no, not really. It's all about the creatinine clearance of patient and the discussion with the patient. It's interesting that whole cisplatin eligibility criteria, your criteria, are very similar to us in choosing diversion of orthotopic neobladder, for instance. I always say, if you got cisplatin, you're eligible, period. Creatinine clearance of 40 is a little bit borderline for us as well for orthotopic diversion, although we do have some data with patients with some CKD doing quite well with orthotopic neobladders as well. But in terms of regimen, no, not at all.
Okay, so let's hear what you have to say. When would you use EV plus P in a perioperative setting for muscle-invasive bladder cancer? 1, for cisplatin-eligible patients. 2, for cisplatin-ineligible patients. 3, for any patient regardless of cisplatin eligibility status. Or 4, I'm not sure. Please log in your answers. Okay, it looks like the winner is for any patient regardless of cisplatin eligibility status. Okay, and we have a question from the webcast. Dr. Gupta, how has pathological complete response become an important endpoint? How has it changed how we understand data in clinical impact?
Yeah, I think we have to see it in the context of, the overall survival as well, because in Niagara, we did not see that the pathologic complete responses were significantly better than just GEM-CIS, but still we had the overall survival advantage. So I think in the era of immunotherapy, pathologic complete response is not the only thing. We have to look at the survival data, but having said that, the pathologic complete responses with EV Pembro, both in cisplatin ineligible and cisplatin eligible patients, has superseded anything we have ever seen in the past. And so that's really reassuring. But seeing the pathologic complete response patient in clinic, I know there's a lot of discussion about whether they need adjuvant therapy or they don't need adjuvant therapy. I would say that at this point in time, we have to just follow the protocol. And but if patients have toxicities, we don't have to push through the regimen, especially if they have pathologic complete responses.
Thank you. So tell us more about muscle-invasive bladder cancer and metastatic urothelial cancer.
Thank you. You still have 1 minute left. That was great.
Take it away. It's all yours.
Yes. So continuing this discussion with what Dr. Galsky just presented. So I'll start with the adjuvant therapy in muscle-invasive bladder cancer. We have 3 major trials. The first one to read was IMvigor010, which looked at adjuvant atezolizumab versus observation in high-risk muscle-invasive urothelial cancer. There were some patients included with upper tract disease too. And even though this was a negative trial, did not meet DFS primary endpoint, I would say this is the most important negative trial we have had to date, which has informed our understanding of ctDNA and how to select patients, and we'll discuss that. Checkmate 274, which was led by Dr. Galsky here, was a positive trial in which nivolumab was significantly better than observation in DFS. Overall survival did not meet statistically significant boundaries, but it was trending in that direction. And Ambassador is the other trial which showed that pembrolizumab was better than observation in DFS. OS was negative so far. So we do have these drugs approved, and with now the perioperative regimen becoming approved, we have to put this in the context of that. So big questions in muscle-invasive bladder cancer are who needs treatment, who benefits from it, how is ctDNA playing a role in terms of prognosis and enriching patients for adjuvant immunotherapy. And this is what we learned from IMvigor010 from the translational aspect, that when we selected patients who had ctDNA positive, they showed that atezolizumab did improve outcomes. And that's when they launched the next trial, IMvigor011, which was really a Herculean task to select patients who become ctDNA positive within a year of surgery. So historically, adjuvant therapy has been restricted to the first 12 or 16 weeks for most diseases. And in this, anytime a patient converted ctDNA positive, they were randomized to atezolizumab versus placebo. And this was the data that we saw at ESMO, that this improved, atezolizumab improved DFS in patients compared to placebo. And additionally, there were also improvements in overall survival compared to placebo with a hazard ratio of 0.59. And just recently, before this meeting, FDA approved the adjuvant treatment of adults with MIBC after cystectomy who have ctDNA positivity. And I want to highlight this is just for bladder cancer. There were no upper tract patients in this. And now talking about metastatic setting where we have first seen these ADC immunotherapy combinations. We know that since December 2023, we've had approval of EV and Pembro. And this was the phase 3 EV302 study, which really toppled platinum for the first time. And then we have the Checkmate 901, also led by Dr. Galsky, where GemCis and nivolumab improved survival compared to GemCis. This was only cisplatin eligible population. I want to highlight here that EV Pembro is the preferred category 1 based on the guidelines. And for audience, just to refresh the memory, this was the pivotal trial where patients were treatment naive. They could have received platinum in neoadjuvant or adjuvant setting if it was more than a year ago, but otherwise they were treatment naive. Minimum creatinine clearance was 30, had to be eligible to receive platinums and EV Pembro. They were randomized to EV Pembro versus up to 6 cycles of GemCis or GemCarbo. With EV Pembro, there was a maximum of 2 years for pembrolizumab, and there was no end date for EV, but we know that in the real world, really a patient cannot continue EV indefinitely. And the dual primary endpoints were PFS and OS, and we saw that for the first time, this was really remarkable doubling of overall survival, doubling of progression-free survival compared to chemo. And regardless of cisplatin eligibility, this superiority with EV Pembro was maintained. And we just saw yesterday the updated 3.5-year follow-up presented by Dr. Pauls. And this is really an exciting time in bladder cancer metastatic setting where we are seeing such long-term follow-ups. And we can see here that the hazard ratio is maintained at 0.53. This is really remarkable that estimated 44% patients were alive versus 24% patients in the chemotherapy arm. And CR rates also are double with EV Pembro compared to platinum. And an important thing that we've seen from the subsequent analyses is that 2/3 of patients who had CR actually attained it after getting an initial PR. So everyone doesn't get CR as the best response early on. So that's why with dose modifications and dose reductions, we should try to get patients the maximum benefit of the regimen. And we also saw this cumulative CR over time, highlighting the importance of trying to keep the patient on this regimen, of course, not at any risk, but with the proactive dose reductions whenever needed. And the duration of response also, the probability of maintaining CR at 24 months was in 2/3 of patients with EV Pembro, which is also really remarkable. So once they achieve a CR, they tend to maintain it. And overall survival among patients with CR, very impressive here. Those who those who deepened from PR had similar outcomes. So regardless of whether they have an initial CR or they become subsequent CRs, their outcomes are similar. And another important thing with the EV Pembro regimen is that regardless of liver metastases or sites of metastases, this works. We know immunotherapy and chemotherapy historically in liver metastases doesn't work well, but these patients are really doing well. And just last week, I saw a patient with liver metastases, no evidence of disease, even off treatment now. And I think that is a very gratifying moment for the patients and us. And we also saw that patients can remain on treatment with dose modifications. As you can see, at 6 months, 12 months, 18 months, 24 months, a lot of patients are still remaining on treatment. So at 2 years, about 1/4 of patients remain on treatment. Now, it's not clear if they're on both EV and Pembro or just Pembro, but the median number of cycles of EV was around 9, and that tells us that nobody is getting it for a very, very long time. And when we looked at the quality of life data here, we see that in all domains, whether it's role, physical, social, global health, cognitive or emotional, it favored EV Pembro, especially patients who had moderate pain at baseline. They had a significant improvement in their score, especially if they were symptomatic from the disease. So, and we see that in the clinic. If patients are symptomatic from their disease, and if EV Pembro is working, you can tell that even before doing a scan. And this was the Checkmate 901, where we saw that Nivo and Gemcis improved progression-free survival and overall survival compared to Gemcis alone. And again, we don't want to do cross-trial comparisons, but the improvement is not as dramatic as with EV Pembro, but this is an option for patients who cannot get EV Pembro. This is the phase 3 TOR trial. We have erdafitinib, which is the FGFR3 inhibitor. FGFR alterations can be seen in about 10 to 15% patients with urothelial cancer. And in the phase 3 trial, compared to dealer's choice chemotherapy, erdafitinib improved median overall survival from 7.8 to 12 months. And in the cohort 2 of the TOR trial, the question asked was, if patients progress after platinum, does giving erdafitinib before Pembro, is it that better than giving Pembro before erdafitinib? And in this, we saw that giving Pembro before erdafitinib was actually, so it was a non-inferiority trial. So it means that we should be giving Pembro first before giving erdafitinib. And so the field of antibody-drug conjugates is really exploding now. EV is targeting Nectin-4. We also have other ADCs, and HER2 ADCs are especially attractive in urothelial cancer. From the Destiny pan-tumor trial, which had some patients with bladder cancer, not a lot, but some, they did show activity with HER2 ADC, and FDA has this tumor agnostic approval for patients with HER2 expressing tumors, and notably this is based on the gastric cancer scoring. IHC 3+, although there was activity in the 2+ as well. So if patients don't have any other options, I think one could think of using for those patients. DV is the other HER2 expressing ADC, and last year We saw at ESMO DV and toripalimab in the frontline metastatic urothelial cancer setting showed really good results. This was in patients with HER2 expression. Now, this is not applicable in the US because this study was only in China. But a phase 3 trial of DV and pembrolizumab in the frontline setting compared to platinum has been completed. We also have other ADCs targeting TROP2. In the past, we had the sacituzumab govitecan, which showed some promising activity in single-arm trials, but in the phase 3 trial, it failed to show superiority over chemotherapy, and not only that, there was increased toxicity and toxic deaths. It's been withdrawn from the US market. And this is an emerging TROP2 ADC, Dato-DXd, which is showing some promising activity in the Tropion pan-tumor trial, and it's now being combined with chemo in patients who progress on EV-pembro in the phase 2/3 Tropion urothelial 03 trial. So a lot of exciting trials are going on because, majority of patients respond to EV-pembro, but those who don't really have very hard way ahead because of lack of great options. And yesterday we saw that platinum is a very reasonable option in those patients, resulting in about 20% responses. As Dr. Galsky had mentioned, these agents have different toxicities, and we really need to educate ourselves and our patients to make the regimen easier. Erdafitinib has some very unique toxicities. Even though it is a pill, it is can be a hard regimen if we are not proactive. It can cause rash, hyperphosphatemia, which needs to be monitored very closely, ocular disorders, including retinal detachment, macular issues. So we really need to have connection with an ophthalmologist, and nail disorders and skin disorders. So it really needs a multidisciplinary team approach. EV has unique toxicities which can become debilitating, peripheral neuropathy, motor neuropathy, and if we don't hold the doses, patients can really start falling and have a lot of issues. We need to do a skin check every time we are seeing patients on EV because the rash can become life-threatening if it's TEN or something serious. The ocular disorders are usually superficial corneal toxicities. They are not really life-threatening and can be handled with topical therapy. And again, importance of checking their blood glucose each time, because patients who are not diabetic at baseline can also develop catastrophic diabetes. So we have to check the blood glucose levels, and if it's more than 250, do not give EV, control that first. TDXD can cause pneumonitis and ILD, which has become a dose-limiting side effect of this. So we have to be very proactive with doing scans, starting steroids early, and then monitoring for that. And Dato-DXd has oral mucositis and stomatitis as main side effects for which we need to have counseling and using mouthwashes and monitoring these patients. So for the most part, for EV, skin reactions, if it's low-grade rash, we should still, if somebody starts EV pembro and early on they get a rash, it's most likely probably from EV. So we should hold the EV dose, give topical steroids, antihistamines, and if that doesn't get better, can attribute it to pembro too. We need to start systemic steroids, and no need to keep pushing EV till the rash gets better. And if it's a serious rash, then I would not use EV again. Peripheral neuropathy, again, this is a cumulative toxicity, tends to occur after a while, after patients have been on EV for a while. So we really have no reason to keep pushing through it, because once it's grade 2, it's already resulting in debilitating daily tasks. So hold the dose. And in our experience, we are seeing that patients really do well when you hold the dose. We are not compromising their outcomes. And many times they can even remain off the dose for a while, and the scan keeps looking great. Ocular disorders can be managed by prophylactic artificial tears. Hyperglycemia, like I said, is really easy to fix. We don't need to hold it forever. We control that, and then we can give it. Pneumonitis is also seen frequently with EV, and again, we have to do imaging, follow the patient for start steroids if needed. So it's really a multidisciplinary team approach, and important provider-patient discussion points are to counsel patients to let us know if there's any rash, send pictures on my chart or whatever EMR they're using, and for the team taking care of these patients to really don't forget to ask these questions and do a good physical exam each time. And it's not really that much time consuming to do a quick grip test or have them walk to see if they're being affected by the EV toxicities. So please answer this question on your device on management of AEs associated with these novel therapies. And I'll hand over to Dr. Galsky after that.
Okay, so let's, if everyone has been able to get the QR code, we'll move on to Gloria. So Gloria is 79 years old. She presents with hematuria, has a bladder mass, diagnosed with urothelial cancer. She undergoes a staging evaluation, which shows several retroperitoneal and pelvic lymph nodes. During her workup, she is found to have a creatinine clearance of 60, an ECOG performance status of 1, has hypertension and mild anemia, no neuropathy, hearing loss, or CHF, no history of autoimmune diseases, and no FGFR3 alterations. So Dr. Gupta, how do you counsel Gloria?
So we'll discuss the EV Pembro, which is the preferred frontline option, and looks like this patient is otherwise pretty fit. Creatinine clearance is not a deterrent. Minimum is 30. It's not, EV is not cleared by the kidneys. She has no neuropathy, no autoimmune disease, so there's no contraindication to using Pembro either. So I would discuss EV Pembro with her.
And what if her histology showed that she had 90% sarcomatoid histology? Would that change your management?
No, in the EV302, any urothelial component was okay, although if a patient has pure squamous, I tend to use Gemcis nivolumab.
So you start treatment, and what if toxicities develop? You took us through some individual toxicities. If you dose reduce EV, do you ever go back up?
No, never. I either dose reduce, if I'm holding EV for a significant toxicity and I resume it at a dose reduced level, I do not go back up.
And what do you tell patients about expectations for response with EV Pembro? When might they see those responses?
So, in our, with EV Pembro, if patients are responding, we usually see it at the time of the first evaluation at 3 months. And having said that, if they have a partial response, then there's a possibility that 2/3 of them will convert to a CR. But if they're really progressing on that first scan, then I begin to worry about that patient, and I do a quick second scan and try to switch therapies. But I think for the most part, even on the trials, we were seeing responses at the 9-week scans.
And on average, how long do you generally end up giving EV, Pembro, either drug?
So that depends on the patient. If a patient has a sustained CR on several scans and they are developing some toxicities, I drop EV because we've seen, median number of cycles was 9. Try to keep them on Pembro, but start talking about, stopping Pembro at some time too, even before 2 years, if, let's say, sustained CRs, ctDNA negative. But again, case-by-case discussion. I don't push EV through toxicities, but I had a patient who was on the EV302 study and got EV for over 2 years. So I think it depends on patient to patient.
And what if Gloria presented in a similar way, muscle-invasive bladder cancer, but initial scan showed no evidence of radiographic metastatic disease? She received EV Pembro perioperatively, and 6 months after finishing Pembro, she develops metastatic recurrence. Does that change your management?
So if the patient received EV Pembro, underwent cystectomy, and now has metastatic disease, yes. So I would not give EV Pembro again. I would offer platinum this setting. And since this patient did not have any genomic alterations.
And what if it was a year since finishing EV Pembro? Does that change how you think about it?
Yeah, I think that would depend on what the initial response was to EV Pembro at cystectomy. If the patient had a complete response, then we could talk about rechallenging.
Dr. Daneshmand, this patient has a bladder mass and some pelvic and retroperitoneal nodes, but no visceral involvement. She receives EV Pembro, has a complete response in the nodes, still has a mass present in the bladder. What do you think about cystectomy in that situation?
Yeah, I wrote an editorial in ASCO Post about this, that don't forget the bladder, and make sure you still keep your relationship with the urologist, because we do have to look. There can be disparate responses in the visceral and retroperitoneal lymph nodes in the bladder. So it's important to still scope the patient and do a TURBT. So let's say the patient has responded in the metastatic sites, and we have confirmed that through at least 2 scans, and has a muscle invasive component to the bladder. Yes, we would consider doing a cystectomy in a patient who is otherwise a candidate, because of potential resistance in different sites. The other would be ureteral obstruction. We do see some patients who have really advanced disease, have a tremendous response, but are left with bilateral ureteral strictures, essentially, same way we see in radiation. I think those patients we should at least consider they need a diversion of some sort, and I would feel uncomfortable leaving the bladder in place and just diverting or reimplanting their ureter. Obviously, with every patient is different. But yeah, don't forget to continue surveillance of the bladder. We've actually had some patients have had complete responses, like Shilpa just described, after several years, then develop hematuria, and we go in there, they have de novo tumors. Yeah. And they don't necessarily need a cystectomy. We've treated patients with intravesical therapy and gone sort of backwards and treated with them with BCG or other intravesical therapy. So again, just don't forget the bladder. I think these patients should undergo monitoring surveillance cystoscopies at least every 4 to 6 months.
Dr. Gupta, some questions from the audience. Are there protocols for effective dose reduction of EV?
I think the guidance on the EV is pretty clear. I recommend starting on full dose 1.25 mg per kg, because we saw some data with the PKs that those patients had more responses, but be very quick to reducing the dose. So if the first dose reduction will be 1 milligram per kilogram, the next one is 0.75. So that's the guidance I follow.
If a patient with metastatic urothelial cancer has an FGFR3 alteration, and by alterations we generally mean activating mutations, activating somatic mutations, do you go straight to ERTA as treatment of choice?
No, I don't. I've used platinum after EV Pembro.
Okay. A few more nuances to Gloria's presentation. So what if her husband told you she had fallen twice in the past week when you see her for initial consultation? Does that impact your choice of treatment?
Yeah, it would impact, if she has, what are the causes for the falls? I mean, if they are mechanical causes versus neurologic causes, if she already has baseline neuropathy, which is resulting in falls, I would be very hesitant to offer EV to her.
Okay, let's move on. Critical to remember the voice of our patients in informing everything that we do. And so the World Bladder Cancer Patient Coalition is a resource for you. You can see information here about support, education, policy, and collaboration.
And I want to add, Matt, that they have come out with really nice patient brochures in different languages to help patients globally.
Incredibly important resource. Here's the QR code for asking any questions. We have a bunch of questions that came in. So let's go through the rest of these. So for Keynote 905, the path CR was 57%, which is 3 cycles of EV Pembro. Keynote B15, the path CR is 55.8% with 4 cycles of EV Pembro in the neoadjuvant setting. Do you foresee that we're moving to 3 cycles of neoadjuvant EV Pembro, regardless of cisplatin eligibility, and any role for continuing EV in the setting of a path CR?
That's a $1 million question. looking at Keynote 905 and B15, we know, Matt, from the B15, not everybody could get the 4 cycles, and the pathologic CRs were pretty much identical. And now we've seen data from Volga that 3 cycles of EV plus IO, we don't know the details, but it's a positive study. So I think, to me, it's not much of a difference between 3 and 4 versus giving EV pembro before cystectomy.
I agree with you. I think it is splitting hairs a little bit. On the other hand, cystectomy is still a significant operation. The ability to get in systemic therapy after cystectomy is not insignificant. Even though the PathCR data lines up pretty well, the time to event data is a little bit different between the 2 studies, and one could attribute that to the fact that the patients were different. The other thing that was different, though, is that the number of patients who received the adjuvant portion was lower in 905. So that's sort of my justification for trying to get in the treatment before surgery.
And I want to also add that, for the whole idea of EV pembro replacing platinum, like, we don't really want to be in a situation where we are calculating cisplatin eligibility, whether to give 3 or 4, right?
Sure.
So I think that will become confusing also. But yeah, I agree with you. The populations, and I think the 4 cycles was probably chosen because the control arm had 4 cycles.
That's exactly right. That's exactly right. And I think when it comes down to it, oftentimes this is sorted out in clinical practice. In a patient sailing through therapy with minimal side effects, then 4 cycles make sense. And if they're not, then there's certainly clinical evidence to stop at 3. How long can a patient stay on EV pembro in the metastatic setting?
I mean, in the study, there was no end date. We've seen that median number of cycles was 9. Having said that, there's a wide range. Like, I had a patient who was on it for over 2 years. A lot of patients come off before 6 cycles. So I think it all depends from patient to patient. But really, if we are adequately reducing the doses, withholding the doses, we can maximize the mileage of this regimen for every patient.
Given the expanding treatment landscape for bladder cancer from an intravesical therapy standpoint, how do you prioritize shared decision-making in patients who have competing comorbidities, lifestyle constraints, and treatment preferences? So, Sia, you present all of these options to all patients, or do you present one option that you think makes the most sense for them?
Yeah, no, we tend to have a conversation about the various options. Obviously, sometimes there's information overload. So if we know a patient is not eligible for one of the treatments for whatever reason, we don't mention it because it becomes a very, very long conversation and complete mass confusion. But we still prioritize clinical trials actually in that setting because we're always looking for novel treatments and better treatments. So if they're not a clinical trial option, then we move to the other treatments. And yes, it is truly a shared decision-making where we're presenting the data to the patients and having them choose. There are nuances about each one, making it perhaps more attractive to the patient versus not. So I sort of try to let the patient choose, and if they say whatever you say, then we go with what's available.
Any role for ctDNA testing in the non-muscle invasive bladder cancer setting?
Yeah, it's a good question, and I don't think it's been answered yet. I think the concentration right now has been on urinary tumor DNA in most of the studies, and not so much ctDNA. The idea being that non-muscle invasive bladder cancer should theoretically have very low levels of circulating tumor DNA. Having said that, there's an ongoing study that will, it's more of a registry basically, that will enroll many patients with high risk, very high risk disease, high grade T1s with and without LVI and things like that. So I personally don't think there's any role for ctDNA testing in patients with high grade TA or CIS, that those patients should not have any metastatic disease or any circulating tumor DNA. But in patients in whom we think there may be upstaging, so high-risk T1 with CIS, with or without LVI, lymphovascular invasions. Those patients are at high risk of progression to T2 or have T2 at presentation. and even positive lymph nodes. We did a study looking at T1, and 15% of patients with T1 disease going to cystectomy had positive lymph nodes, obviously selection bias and all that. So yes, and I think very high-risk patients, but not so much in the lower risk.
Dr. Gupta, in the last minute, what are you most excited about at ASCO this year?
I think seeing the follow-up data was reassuring from EV302, and I think looking at novel ADC immunotherapy combinations, it's really an exciting time for us to see all these advances.
Absolutely, and we saw some readouts with Nectin-4-based ADCs after EV, showing some activity, so the target still seems to be relevant even after progression on EV.
Absolutely.
So I want to thank everyone in the room for joining us and everyone joining online. Thank you. Here's the QR code. Please visit this site to claim credit and stay tuned for the online activity based on this event. Thank you. Have a great night. Have a great rest of ASCO.
Thank you.
Thank you.